So I am kind of summarizing the whole course, when to start treatment and what. So the question is when to start treatment. The answer is easy. In a glaucoma suspect, treat a glaucoma suspect if the actual pressure is outside the target IOP. So what target IOP is? It's the IOP at which you feel the eye will be safe at. So to set target pressure, for starters, the important things are, if the pressure, actual pressure, and that is corrected pressure, is 28 to 30, then you have to start treatment in all cases. Why? Because most authors believe that at a pressure of 28 to 30, the risk of retinal vascular occlusion increases tremendously. Okay. So the risk of retinal vascular occlusion increases tremendously at a pressure of above 28. So if this is the benchmark pressure to start treatment in all glaucoma suspects, 28 and above, then I will lower the pressure to start treatment if in addition to this or less than 28 pressure, there are other findings present. That means I will lower the target if, as Dr. Tejwani has told us, that if the CD ratio is more than 0.5, vertical CD ratio, if there is a rim irregularity, notch is there, if there is a disc hemorrhage, as you can see here, inferotemporal notch with a disc hemorrhage. If already a retinal vein occlusion is present, then you have to lower the pressure at which the patient has come at. Suppose he comes at 26 pressure also, if within RVO, you have to lower it further. Then family history of glaucoma, you have to lower the target pressure by 1 to 2 points each. Other eye already having glaucoma, and if the other eye is already blind with glaucoma, then you have to be more cautious in treating this eye. Further on, with a thin cornea, and for all practical purposes in your busy clinical practice, thin cornea will be less than 500 micron. Though ideal is 480, but 500 se niche, you should lower it by 1 to 2 points each again. Then OCT defect, that is the role I feel which sir was saying. If everything is normal and the OCT is showing one sector defect, you don't ignore it, you don't start treatment also. But you lower the target pressure by 1 to 2 points if the OCT is showing an early defect. Having said this, a lot of you deal with rural patients, you deal with semi-literate patients. If the follow-up of the patient is doubtful, then it is better to start treatment, even if it means over-treatment in some glaucoma suspects. Some other points to consider from those of you from Kashmir, from hilly areas, Himachal, Uttaranchal, and from South India, remember exfoliation. You have to lower the target pressure again by 1 to 2 points from 28. Then one-eyed patients, I've already said, and one-eyed patient for any reason, and especially if it is glaucoma, you have to be a little more aggressive in treating the only eye left. Other considerations, especially in normal tension glaucoma suspects, will be IOP fluctuations. We've discussed office diurnal, we've discussed the role. I think let's move on. Sleep apnea, pretty common in males especially who are obese and middle age. So this will be an independent risk factor. We discussed earlier before you joined us that black races and Indian races are brown. Brown races are at intermediate risk to develop glaucoma. So we have to be a little more aggressive in treating our own population. Then other things, again, migraine, Raynaud's, and myopia, consider that as especially for NTG. How much so once you have decided to treat, how much to lower it? For ocular hypertension and early glaucoma, aim for lowering it by 20% from what the pressure is. This is for starters. For NTG, however, the study has taught us that once you know it is NTG and you want to lower the pressure, aim for 30% lowering to begin with only. Then medical management, now coming to the second part, what treatment to start? So for ocular hypertension and early glaucoma, can the audience tell me how much was the lowering required when you want to treat an early glaucoma? 20%. Now keep this in mind, and that means the question asked is what treatment to start? My answer is you can start any of the drugs mentioned here. These are all the classes of drugs available to us in India. Why you can start any of these? Because each one of them should give you 20 to 25% IOP reduction when used as single drugs. And 20% was the reduction we wanted in early glaucoma. So when IOP is the only consideration, then you can actually start any of them from IOP constraint. But that is not the only thing. You have to look at the side effects also and match the side effect profile with your patient's eye or the patient's body. The usual first choice, I will tell you in my practice, and for most of us here, will be a prostaglandin. Why a prostaglandin? Because of the reasons mentioned here. It will give you highest IOP lowering, 30 to 35%, much more than 20 to 25%. And this 30 to 35% is especially good for NTG, because NTG, how much lowering we needed? 30%. Why give a combination of drugs when one drug can do that wonder for you? Then my reason for choosing prostaglandin as the first choice is actually the last line of the slide. This is the drug which gives you good day and nighttime control of IOP. Timolol is a favorite. I'll come to it in the next slide. Timolol is a favorite for a lot of us in the audience for its cost factor, but it is a doubtful. In fact, it does not lower the nighttime control of IOP very good. Patient comes to you in the morning time with a pressure of 14 on Timolol. You are so happy. But raat ko, night mein, if the pressure increases, he's going to have damage. So this for me, this one and the last one are the compelling factors for choosing a prostaglandin. Timolol, most used, I use it often too, because of the cost factor. I think for India, this is still the hot favorite. But keep in mind the problems or the issues with Timolol. It gives you only 20 to 25% IOP lowering, mostly 20%, and that may not suffice in a lot of glaucoma suspect patients. Then nighttime control, I've told you it's doubtful. What about tachyphylaxis? Aapne 6 months diya, you know the problems of short-term and long-term usage, tachyphylaxis with Timolol. Keep that in mind. It's better to change it after some time, even if the cost is a factor. Timolol is the most dry eye causing glaucoma med available to us in India today. Keep that in mind also. And cardiac and respiratory side effects we are all familiar with. Keep in mind, it is known to worsen depression and hallucinations, psychiatric problems, and hyperlipidemias as well. Keep these in mind and then choose Timolol as your favorite drug. So few points and the last two slides. We have discussed in this when Dr. Tanuj was presenting that nearly 50%, if not more, everyone's practice here, everyone sitting here, everyone's practice, half or more of glaucoma suspects are angle closure glaucoma, one spectrum of angle closure or the other. So if you are not doing as many lasers or close to those many, then you are not doing the right treatment. Only medical management and angle closure is a crime. Half of them are actually missed or mismanaged by general ophthalmologists, and this is a state which we must correct in India. And remember, if you don't do a laser, just continue meds in angle closure, they will progress despite medicines. Every IOP, the other flip point is, every ocular hypertension, every IOP above 21 does not need treatment. Purvi has told us, on Shiots, 24.4 pressure is recorded. No disc is examined, nothing else is taken into account, and a Timolol is written. It is happening in a lot of situations in India. That is not correct. Individualize the target pressure of each eye, treat each eye on its merit. And follow up. Dr. Naik will agree with me, lot of the glaucoma suspects do not need treatment when you first examine them. You have to follow them up. You have to tell them 6 months to 1 year as per your judgment. And the guideline to treat glaucoma suspect, if one word you take home today from this course, is progression. So progression can be on disc, examination clinically, on OCT or HRT, whatever you have, or on field, or all three of them. Then, yes, progression on the same OCT machine, done 6 months or 1 year, you should start treatment. Progression is the mantra to start treatment in glaucoma suspects. Remember, they will not go blind over 6 months. They may develop a bit of mean deviation may go down by 1% is not equal to blindness. And also keep in mind for suggestive symptoms of angle closure of pain, headache, colored halos, which may suggest. Thank you so much for all the faculty who participated and all the learned audience who came early in the morning. At 9:30, I was telling Dr. Sushma, the hall was full. I was expecting less than 15 people to be in the hall today. Thank you so much. Time over? Yeah. So I think the time is over. We've had good discussion during the course itself. We are all available. I hope you notice my email to correspond further is my full name, deventuli@gmail.com. Please mention the faculty you want to address the question to. I'll be happy to pass on, and I know they will correspond back to you. Thank you so much again, and have a great AIUS. Thank you so much, sir. Thank you, thank you. Thank you, Professor Das, and thank you all the glaucoma and the general colleagues here. Thank you.